And then where did this breast conservation surgery, when did this come about?
Yeah. So I worked with in Countess of Chester Hospital.
Right.
And there was a focused breast unit over there.
Which year was this?
This was in 1998.
Okay.
Yeah. 97, 98.
Right.
So at that time, I mean, in Nair Hospital, we didn't have a breast unit. They are just coming up now, after 30, 35 years.
Really?
Yes. But in those days, it used to be like one consultant who would look after breast. And then the plastic surgeon used to do the reconstruction job, which at that time was mainly implant based. So now everything has changed.
Also, what has changed?
Yeah, I mean, it has advanced into a field of its own, which is breast oncoplasty. So, there are three levels of oncoplasty, if I could just touch upon them in brief.
Absolutely.
Yeah. So, as we all know, any cancer has stages, right? So, stage 1 and stage 2 are considered curable stages. And त्याच्यानंतर stage 3, stage 4, you have to do something to downstage the cancer and then treat it operatively. So, in the initial stages with a smaller lesion, what we do is a level 1 oncoplasty. So, basically, the idea is onco and plasty. So, we have to keep oncological safety in mind and at the same time giving good cosmetic outcome to the patient. So, with a small lump, it is a level 1. That means whenever we remove the lump, the lesion with a good oncologically safe margin, we need to create good cosmetic outcome in terms of maintaining the shape of the breast. This we do level 1 when the defect is less than 20% of the breast volume. And we need to see to it that there is not much asymmetry compared to the other breast. So there are certain procedures where we mobilize the breast parenchyma itself and fill in the gap.
Okay. Fill with what?
Fill with breast tissue itself.
Okay.
So we mobilize the breast parenchyma because, as you know, the breast is a very fatty structure, fat along with glands. And there are various different criteria in which we decide which patient needs what. If there is a larger defect between 20 to 50%, then we do something which is known as a level 2 oncoplasty. So that includes a variety of procedures, but if we talk about autologous procedures which are not implant based, then there is something like perforator based flaps or fat skin and subcutaneous flaps or myocutaneous flaps. So those are mobilized from the tissue, the fatty tissue in the axilla, or the infraaxillary tissue where we tend to have a lot of fat in that area, in the lateral chest wall. So in most patients we use that fat. Then the viability of that flap is very important. So we find out the vascularity of the flap which we mobilize by doing a Doppler test, a handheld Doppler, and then we base the flaps accordingly.
Okay.
So the focus has to be on giving good cosmetic outcome to the patient.
Right. But this is usually before the metastasis has happened.
Yes.
Only then you can do this, है ना?
Now, with advances in medical oncology, there are so many newer chemotherapeutic agents, immunotherapeutic agents, which are very targeted, and they cause downstaging of that tumor very easily. So we can do a breast conservation even in patients who have a higher stage after neoadjuvant treatment. So that
really?
Yes, it is very much possible, and it is a big advantage because nowadays we are seeing very young patients.
Yeah, definitely.
So a mastectomy is definitely not a first choice for a young patient.
But this oncoplastic procedures can also be done in a fibroadenoma?
They can be done if it is a large fibroadenoma.
Yeah, the benign ones, na?
Yeah, the benign ones. So that is an extension of the indication of oncoplasty.
Okay.
Most of the fibroadenomas don't need any oncoplastic procedure.
Right.
Yeah.
Nice. So